Well, hello and welcome to our Kauai Health Community Engagement webinar. My name is Deborah Volleson and I'm joined today by Gary Herbst. And we're going to share some information, we're going to respond to your questions, and we're going to just give you some updates on the happenings around Kauai Health. Thank you. We know this is not your normal day for meeting us. We had to move it to a Wednesday because Gary's got important stuff to do, and I'm kidding.
Not that our participants don't
Yes,
have important things
yeah.
to do, but yeah, and I appreciate everybody's flexibility. Tomorrow at noon, I'll be joining my fellow CEOs from up and down the San Joaquin Valley here. We have what's called the Hospital Council of Northern and Central California. So all of us hospitals located in Northern and Central California, we meet generally once a quarter to share ideas and common issues and where there are opportunities to collaborate. And tomorrow happens to be the day that they're meeting. So
Yeah, well, this group is flexible, and we're used to all of the change, right? We've been changing now since 2020.
We have.
And but Gary, it's always an honor to sit down with you and to answer some of the questions that the community members send in. So we're going to start today. We're going to talk about the urgent care on Demery. Social media, there were several posts that were put out about this urgent care is closed from this hour to this hour. So give us the background as to why an urgent care would close.
Yeah, so normally they don't, and I apologize for the frustration that is causing our community. Our two urgent care centers, one on Court Street and one on Demery and Flagstaff, I think is the cross street on it. Very, very busy urgent care centers, very convenient for our patients, and definitely when it's not a matter that is of an emergency level, we really like to see people utilize our urgent care centers. But unfortunately, we've been experiencing a shortage in practitioners. Urgent care centers are traditionally staffed with nurse practitioners and physician assistants, but overseen and supervised and generally in the presence of a physician as well. Dr. Dan Brown, longtime emergency medicine physician in our community, oversees both those urgent care centers. And probably one of the hottest commodities, I don't mean to refer to them that way, right now in healthcare are advanced practice providers. So those are the nurse practitioners and the physician assistants. So it's a very hot market. We're all competing for those same people. We've had some shortages that have caused us to have to close or shorten our hours, and it is a temporary condition, but I know it's been very impactful, particularly in June and July. We are onboarding as many advanced practice providers as we can. I've signed a number of recent applications for additional APPs. We think we will have it fully resolved by the end of this month and should not see any further closures or reduced hours after this point. So I want to thank a number of our third-year emergency medicine residents that are licensed doctors and able to moonlight, that they've stepped up and said we'd be happy to do some shifts in the urgent care centers to keep that continuity. So we're doing everything we possibly can to get back to full service.
Okay, thank you, Gary. So the next question is about the air conditioning at our labor and delivery department. So we've been notified or people have been telling us for a few weeks now that the air conditioning is struggling in that department. And then some questions came in saying it's not fixed, it's hot, the babies are hot, the moms are hot. And as somebody who delivered babies, you do not want to be hot in labor and delivery. So do you have any answers for us on that?
Not having delivered babies myself, I can only imagine. Yeah, I actually, Carrie Noweski, our chief nursing officer, and myself, we actually were up rounding on labor and delivery and mother baby in the L&D triage area just a few weeks ago, a couple weeks ago actually, and it definitely, we were hearing the feedback that it was warm, particularly in the labor and delivery area. The L&D triage area, which is kind of like a obstetrical emergency department, we had been able to bring in some portable air conditioning units, and actually were able to drop the temperature lower than it's ever been. And the staff there said, "This is wonderful. Can we keep this forever?" But unfortunately, that would be almost impossible to do. But it's a great question, and it's I wouldn't say it's unprecedented, but it's highly unusual that we're experiencing this right now. So labor and delivery is located in what we call the East Expansion. So it's considered part of the Mineral King Wing. It actually opened in the early 1990s. In fact, I still remember walking down the sidewalk of Willow Street headed to the Human Resources Department, where I was going to interview for a job at CWEA. And looked over to my right, and I could see the steel girders, the framing of the East Expansion. That was back in 1992. So it was completed and opened shortly thereafter. That's a good part of our emergency department, is in the East Expansion on the ground floor. Labor and delivery, the Broderick Pavilion, all located in that East Expansion. So the way air conditioning works there is it relies 100% on the ambient air that is drawn from the outside, comes in, rolls across the air handlers, the cooling coils, and then is converted into cool air that cools the L&D rooms and really the entire East Expansion. So typically, when we have days of 110 degrees, and that's the temperature of the air that's coming in, our coils are actually able to bring that temperature down below 70 degrees. So anywhere from 65 to 68 degrees, which sounds cool. And if that's the temperature in my house, and my wife would probably be putting a jacket or a blanket on at that temperature. But when you're in labor, that's probably still feels
warm.
hot.
Yes.
And so bringing it down to 65 to 68 in labor and delivery doesn't work. It's not low enough. You contrast that with like the offices and other areas in the East Wing or in the Mineral King Wing, where it's not bringing the outside air in, it's recirculating the interior air. And so that's why it feels so much cooler in those interior spaces, because you're starting with a much cooler temperature air that's coming in, that's being further cooled and recirculating. So there's a number of things that are contributing to the ineffectiveness, I guess, of being able to cool the temperatures further. Number one is we're experiencing pretty extreme humidity for this time of year. And according to our engineers, that high levels of humidity slow the speed of the airflow as it comes across the coils. And so when we have this 110 degree outside air coming in and it's moving slowly over those coils instead of rapidly cooling, it's inhibiting our ability to bring that temperature down. Kevin also says that while we have filters that, because unfortunately, there's a lot of pollutants in the air too. And so as that outside air comes in, we have filters that try to filter out those pollutants, but unfortunately they're at a high enough level, but that they are also inhibiting the ability of those coils and those air handlers to cool that temperature. We clean those filters constantly. But Kevin said what we really need to do is to be able to shut down, for like anywhere from 10 to 12 hours to really do an effective cleaning. But to do that would require that we bring in massive portable air handlers that literally could handle the entire east wing. Again, first floor, second floor, everything there. And no such air handler exists, or at least not in this area. And so it's impractical to get that 10 to 12 hour cleaning. So as a result, the best they're able to do with continuous cleaning is about 4 hours a day. And most days it's probably 2 to 3 hours. So it's not accomplishing that deep, continuous cleaning that we would really need to do under the conditions that we're in right now with this high humidity and high heat. So the team is in there. They're doing everything they can. Again, they're facing conditions that are unusual. We've even talked, is it a possibility to move those services out of the East expansion, to move labor and delivery?
Mother, baby.
Yeah,
Temporarily.
yeah. So they're exploring that. Obviously, that comes at a great effort to be able to move a labor and delivery unit to some other location in the hospital. And so I appreciate and I'm extremely sorry that our patients and our staff too, they're experiencing those higher temperatures. Our maintenance crew is doing everything they can. When we were up there rounding, I think there were 6 maintenance workers, all doing everything they could to try to bring that down. If we could, we're looking to see, do those coils need to be replaced? Is there some way to bump them up, add additional coils? We're exploring everything we can, and we know it's very uncomfortable for our moms right now, but we're doing our very best to address it.
But the patients are all safe, right? Babies and moms, everybody safe?
Yes, just not as comfortable as
Okay.
they would like to be.
Okay.
Yeah, I mean, you think about 65 to 68, that'd be very comfortable. But again, that's comfortable sitting here, but not when you're in active labor, and we know that.
Yeah. Okay, thank you, Gary. So the CrowdStrike bug that took down most of the world this week.
Did you say crowd or cloud?
CrowdStrike.
CrowdStrike? Did you say
CrowdStrike.
crowd? Crowd, okay.
I am married to an IT guy.
Oh, okay.
CrowdStrike.
All right. I'd never heard of CrowdStrike.
Took me a while to figure that out.
Yeah.
CrowdStrike. I hadn't heard of it either. So
Yeah.
I thought it was some sort of concert thing,
Oh,
like
gotcha.
CrowdStrike. I'm
Yeah.
like, oh, yeah.
Yeah,
So it was a bug.
yes.
My phone started ringing at like 3:00 in the morning that day. So I've been hearing about it constantly, but people woke up to most of the world. I mean, banks shut down, airports shut down. We've still got people in airports waiting to get out on their flights. But then they also said, and hospitals. So was Kauai affected in any way with CrowdStrike?
Yes, to a very minor extent. So CrowdStrike, as I understand, is kind of a cyber security protection platform that interfaces very closely with the Microsoft operating system, which is deployed extensively throughout Kauai Health. My understanding, this was not actually a cyber attack, which is what we read about often, where industries, hospitals are crippled because of a major cyber attack. This was not that. This was simply CrowdStrike trying to make a software update to their system that apparently there was an unidentified computer bug embedded in that update. And when they went to update, it literally knocked out the Microsoft operating system across the world. So it was pretty severe. The executive team happened to be in a meeting on Friday, which included Doug Leeper, our Chief Information and Cybersecurity Officer. So he was briefing us throughout the day on if we were experiencing anything. It actually, while it didn't directly affect Kauai's computer operations, it affected some of our vendors. And so we actually, a supply delivery that we should have received on Friday was delayed until Saturday, as our vendor was struggling with the effects of CrowdStrike on them. We did hear of hospitals in Fresno that were impacted by it. We heard from the VA hospital in Fresno that it had crippled their surgical abilities, and that they would be referring their surgical cases to nearby hospitals, including Kauai. So we went on alert for that, although I don't think we ever did receive any VA surgical transfers throughout that time period. So I haven't heard an update. I don't know if all systems, are across the country are up and running now at this point. But fortunately, we use a different company other than CrowdStrike. I think it's a Dell product. So we dodged this one, so to speak.
Yeah, and I was talking to Daniel before it started that it's kind of like we weren't affected, but it's a good little reminder to us that we've got to be vigilant because tech goes down, we're all in trouble. So
well, that's why we all know about the test environment and production. And you don't ever skip the extensive testing before you move it into production. So,
yeah. All right. Thank you, Gary. So SB 525, we talked about it most of the year last year. We rolled it out. We did all of this stuff, and then the state pulled it back. And so the question that was submitted was, how is Kauai handling the frustration of being on the roller coaster with the state about, you got to pay, just kidding, you don't have to pay, but you've already rolled out payment. So a couple of things that they've asked. So tell me about your frustration, which I'm sure you're happy to. What was the total cost? And is there anything we can do legally or negotiate with the state in any way for them to help us cover some of the cost of a mandate that they imposed and then said, just kidding?
Yeah, we are definitely frustrated, but we were already incredibly frustrated to see SB 525 signed into law by the governor. That triggered our initial frustration, which we've never come down off of. So, but the governor has, and with the legislative support, has certainly escalated the level of frustration that healthcare providers are feeling up and down the state. Unfortunately, the events that have occurred. So, we're told that the effective date for SB 525 is June 1st, 2024. And many organizations, including ours, we can't wait till May 31st to implement these things. So there's a lot of analysis that has to go into it too. It's not just simply, okay, everybody that's below $18 an hour, which was the minimum wage for hospitals like us, just raise everybody that's below that 18, just raise them to the 18. Well, we also had to look at compression. We had to look at, okay, what about, those employees, those supervisors, or the people that have been here longer, and now they're at 18 too. And so there was a lot of pre-planning that had to go into being able to implement and go live by June 1st. And so we really started working on this in December and January. We also had the $20 minimum wage for fast food workers that was going into effect on April 1. And how was that going to impact our dietary services, our food workers, our EVS workers, who are not fast food workers, but now you can make more money working at McDonald's than you can working at Kauai, preparing meals for patients. That's not right. And so we had that going on. But probably even more significantly, just the workforce shortages that we've been talking about over the last several years, those have not gone away. Kauai still has almost 500 open positions. Still close to 200 open RN positions, and that's being, experienced by hospitals up and down the state. So there's still this tremendous demand for healthcare workers that is pushing up wage rates that are market force driven as opposed to regulatorily driven. So we got all of these compounding pressures to increase wages. And so we had to start putting those in place really beginning back in late February, early March. And we've been making those adjustments all the way up to today. Our plan was to finally have all of the adjustments in place by the end of July, which will happen. So we couldn't wait. And when the governor said, "Hey, I'm gonna ask that the legislature push the effective date from June 1 to July 1, so that way I could push it into next fiscal year and not have any of it hit me this fiscal year," because apparently, unbeknownst to the governor, when he signed this bill into law, he had not been told by his Office of Budget Analysis that this law was actually going to impact the state's annual budget by $4 billion a year, because all of the University of California hospitals, many of the county hospitals, other state healthcare entities are also subject to this increase. So he's kind of saying, had I known that back then, I'm not certain I would have signed this into law. So I wish he had known that. So here he comes along and he delays it to July 1. And so at least he's dodged the bullet to have any of this expense hitting in the month of June. So then he starts working with the legislature, and he's seeing that he's staring down a $25 billion budget deficit before the budget gets passed. And he's saying, now I want to delay this until at least October. And I want to see how much revenue comes in, tax revenue comes into the state coffers in the first quarter of the year, so July, August, September. If it's more than 3% of what we were expecting to come in, then I will immediately implement the wage increase at that time. But if it doesn't, then I reserve the right to further, stall the implementation. And it sounds like he's hinted at that now. And that he's saying, well, now it looks like at least until January 1st of 25, am I going to implement it? We may find out that it continues to get delayed and delayed and delayed. The governor has already reneged on his promise, the new managed care organization tax that he put in place retroactive back to April 1st of 23. It's going to raise close to $20 billion over its 3-year term, and he promised to use half of that to increase Medi-Cal reimbursement rates to doctors and hospitals. Well, because of the budget deficit, he's already said, I'm not going to give any of that to hospitals. I'm going to use all of it, 100% of it, even more than 100%, because he later increased the amount of the managed care tax that he's charging managed care health plans. But he's going to use 100% of that to help fund his budget deficit. So I would not be surprised that we see another delay past January 1st, 2025. But again, hospitals like Kauai, Family Healthcare Network, they were one of the early adopters. They went to $21 an hour right out of the gate. I think it was back in January or December. Many other hospitals up and down the state have already moved on increasing their wage rates to what are going to be the minimum levels. And so Kauai really had to follow suit if we're going to compete for jobs, not only attracting highly qualified, skilled individuals, but keeping our existing employees who now, once again, they have many opportunities. There's many openings up and down the state. And as wages keep getting pushed up and up, it's really a buyer's market, as they say. It's all the leverage is in the hands of our employees right now. And so we felt we had no choice but to make these wage adjustments. It will total to about $32 million a year. And so that's what we built into our budget for the 24-25 year that just started. The brand new year just started on July 1. And so our employees will experience a $32 million increase in their compensation over the next 12 months.
And nothing you can do to try to go back and ask for assistance from the state?
I was really surprised that there weren't organizations that stepped forward and filed, a lawsuit, an injunction against it, although essentially the governor imposed his own injunction by not implementing it. The fact that he waited like literally a week or two before June 1st to announce that he was going to delay it to July 1 was, far too late for many folks. So I'm not aware that anybody actually challenged it. And once you implement, I can't go back to my employees and say, never mind, looks like the law is going to be delayed, so we're going to roll back wages. Once you make them, there's no taking them back. So I don't think there's anything from a legal, standpoint to contest the law. So I think really the only options, and we're now on our own, essentially, as we've always been. We don't ever, get support from the state. And so we just have to now continue to find ways to be more efficient, more cost effective. The biggest challenge we have is that 99.9% of our total operating revenue comes from Medicare, Medi-Cal, and commercial health plans like Anthem Blue Cross, Blue Shield, and so forth. 80% of that 99% comes from Medicare and Medi-Cal. We have zero influence or say over the revenue we're paid from the Medicare and Medi-Cal programs. We could go to the commercial payers and try to negotiate higher rates, and a lot of hospitals, us included, are trying to do that, and we're holding out to them. Look what's happening to our labor costs, and they're saying, well, that's not our problem, that's the state's problem. We didn't cause that, and it's not fair that we as health plans should have to shoulder that burden alone. And we also know that if we're successful in getting increases from those commercial health plans, they're just going to pass those on as higher premiums to our employers, who then will pass it on as higher premiums to their employees. And that's not what we want to do. We don't want to punish our local employers and employees from unfunded mandates that come out of the state legislature and the governor's office. So we'll continue, to look again to ways to streamline our operations, to be more efficient, to negotiate, better supplier contracts. We just recently changed our group purchasing organization, and that, well, we're still with Premier, but we're now affiliated actually through an entity, a health system in Texas, that is now providing us a much lower costs for many of our supply items. And so that will have potentially a multi-million-dollar benefit to us. And then continuing to grow our revenues, opening new services, like our new clinic on Plaza, expanding services, in the cardiac area, orthopedic area, but probably more ideally, just continuing to provide that world-class experience for our patients, so that they don't want to go to SPOC for their knee replacement. They don't want to go to Sansum in Santa Barbara for their colonoscopy. That they would want to go nowhere else but Cahuilla for their health care, because of our outstanding reputation, our wonderful physicians, our nurses, and to create just that world-class experience where you feel that you're really being cared for in a compassionate, empathetic way. And I hear great stories all the time. I just talked to a longtime patient last week that was telling me about the wonderful experience that she has, and that Quia has been there for her and her family their whole lives. That's the kind of relationship and experience we need to create with our entire community. We know that we lose patients to Fresno and other communities, and it's generally those that have commercial insurance, and they have the means and the ability to shop around, and if they need that joint replacement or some other elective procedure, they have options, and we don't want them to consider those options. They would again think of no other place. So we're really on our own, Deborah. It's either through our own cost-cutting measures or revenue growth.
Yeah. And what you were just saying reminded me of an email that I got yesterday from one of our community members that I sent out the announcement about this webinar to. And he said, at this moment, I'm checking out of the hospital. This was my first hospital stay as an adult. And I am very fortunate, and I wanted to share that I was very pleased with the professional care I received, and more importantly, the empathy and genuine concern. I greatly appreciated the care. I was like,
That's nice.
So a lot
and
of
you'll
times,
share that with us.
A lot of times, this group especially, the community advisors and our community engagement team, sometimes they hear a lot of the complaints, because now that they're on our committees and their advisors, they kind of become sounding boards for their friends and their social circle. And so sometimes I think that they might think the only thing we get are complaints, but we do get a lot of great feedback. And that just jumped into my head when you were saying that about the quality care and world-class service. Every patient, every time.
Right.
And Gary, if we can do that,
Yes.
Every patient, every time,
yes,
we don't really have to worry about this.
we don't. And I am the first to acknowledge that we are far from perfect. While we provide world-class care to many, many people, not every person every time. And that is the most important. It's that constancy, it's that consistency. And it disappoints me tremendously, and I probably take it too personally, but I can't help it. I've been here 32 years. Quia has, half my life has been, being a part of Quia. And so I do take it personally, and maybe that's a good thing, because I always think of, my mother, my child, my friend, my wife, and putting us in the shoes of the patient that didn't have a great experience. And so our executive team spent the entire Friday. We had a retreat. We didn't go anywhere fancy. We just went upstairs to our fourth floor classroom.
Tower.
Yeah. But we dedicated the day just focused on how do we continue to elevate the quality and the safety of the care that we provide. We spent a lot of time, talking about patient experience and the feedback that we get, and we started out reading some social media posts that made us cringe, when we hear stories about our staff being rude, being unempathetic, and it's hard to understand, why would you go into healthcare if you weren't committed deeply, passionately about taking care of your friends and family and community during their time of need, when they're scared and anxious and injured and ill. And so we know there's still lots of work to do. The complaints are important because suffering and silence, doesn't give us the opportunity to address it. So as difficult as sometimes it is to read those complaints, to hear about those complaints, we want to know about them. That gives us the opportunity to be better.
Yeah. All right. Thank you, Gary. So moving on to the budget. Do you sometimes just sit back and think, I am the CEO of an organization that has a $900 million plus
Yeah.
budget, and has one of the largest impacts on this county. But it was just passed, the 24-25 budget.
Yeah, wow. The responsibility that you just, no, I'm keenly aware of that responsibility. $900 million, 5,000 employees, 700, providers. We are a very large organization. We're the largest employer of all of Tulare County, and you feel a real sense of responsibility to operate in a successful organization that can continue to offer those employment opportunities, those career opportunities to our employees. I think the Tulare County Economic Development Corporation conducted an economic impact study just a couple of years ago and determined that Cahuilla Health contributed over $1 billion in economic vitality to this county. So clearly we're a part of a much bigger economy supporting our entire community. 900 million is a record. Every year it goes up, obviously, as our population grows and we try to continue to expand our services and our outreach. It's expectedly, increasing every year. In addition to the $900 million operating budget, which close to 60% of that goes towards our employees. So that's their wages and benefits. Probably 100 million of it goes towards supporting our physicians. Because unfortunately, with the poor payer mix that we have in our service area, we would not be able to attract and retain top flight physicians without our ability to provide them some financial support to supplement those professional fees that they can collect from Medicare and Medi-Cal. And so we're a nonprofit public hospital, so not a single penny of that budget goes to shareholders or private owners. It literally all goes into the hands of those who provide the health care. It goes into purchasing the drugs and the supplies and the energy and the food and facilities and everything that we need to provide that outstanding care to our patients and our community. A $14 million capital budget. I think maybe I said that. We'd like it to be higher, but that's, we pretty much fund our capital budget comes out of our operations. Essentially, part of that $900 million goes to fund our capital budget. So new equipment, facilities refurbishment, infrastructure, water systems, energy systems. So all of it goes into that. Unfortunately, because of this significant increase in wages, that $32 million I referenced, that's coming essentially without any increase or nominal. I think we're getting about a 2% increase from Medicare. We're getting nothing from Medi-Cal. We might get anywhere from 2 to 3% from the commercial health plans, but it's not enough to fund not only wages, but we continue to see the cost of drugs. While inflation is coming down, there is still inflation, which means prices are still rising. They're just rising at a slower rate. So, at the height of it, they were, rising, I think in 1 year, 9% or higher. So they're continuing to rise. I think we're at about 3% inflation. So they're not dropping. It's still 9%, and then 5 on top of that. And then so, if you look back over, the pre-inflation period, our pharmaceutical costs, our supply costs have risen 10, 15, 20%. And while that rate of growth is slowing, they're not cheaper. And yet our revenues, our reimbursement rates have not grown, even close to that. And so all those things coming together, we actually are budgeting for a $12 million operating loss next year that we will again, have to kind of fund out of our cash reserves. It will be offset in part by investment earnings on our cash reserves. I think when you factor all those things in, we are budgeting to be about break even when you look at the bottom line after all other non-operating revenues, which are primarily investment earnings. But we're also counting on FEMA. So that's built into that bottom line budget too. I think we built in about $6 million in this coming year, or in the year we're in now. We're feeling very confident. In fact, our first application has already now passed through FEMA. They've completed their analysis. Then it went to the second level of review by an outside entity. It is now passed through them. It is now in the hands of the RAND Corporation, which for some reason they're involved in determining that we haven't already been funded in some fashion. These are mostly, this FEMA claim is for labor, travelers, premium pay, overtime, extra shift incentives, things of that nature. And to demonstrate that it was not funded by any CARES Act provider relief funds. And so we're confident that the RAND Corporation is going to come to that conclusion that we've not already been reimbursed. But we've been told by our consultants that are helping us with this application process that once you make it past FEMA and this first level of review, if you weren't stopped at that point, which is where you would be stopped, you're probably home free. And so we're feeling really good about that. It's just that process, getting through the RAND Corporation, could take up to a year. So we're holding our breath. We're probably going to now lean on our federal legislators, Vince Fong, Jim Costa, to see. They've been willing to help push that. So I think we're going to, ask for some of that help to
now, is
move it
that
along.
is that included in the $12.4 million loss?
No. So the $12.4 million loss, that's taking all that operating revenue, which again is primarily Medicare, Medi-Cal, and commercial insurance, patient care revenue, but it's also the cafeteria and the lifestyle center, and all that stuff goes into the operating revenue. And then we have all those operating expenses of salaries, wages, physician fees, supplies, drugs. And so when you get down to the bottom, that's your operating margin, either a profit or a loss. And for us, it'll be a $12 million loss. But then after that, you have non-operating revenue. And so we have several million from investment earnings on our cash reserves, and then those FEMA funds. And so when you add in the FEMA and investment earnings, I think it's actually in the black, but maybe 2 million, close to break even. Okay. We could not survive long term on a $2 million bottom line margin. So if the FEMA funds, if all 33 million, we only included 6 million in the budget just to be conservative and safe. But if that 33 million should come in, that will be quite a day, quite a celebration, and definitely will make this year much, much different. But we have to remind ourselves and discipline ourselves that it's a one-time. So you can't go out and obligate yourself. I'd love to give our employees, a bigger raise, but I've now committed myself, and we can never take it back. And so one thing that we likely will do this budget, although I can't speak for the board, but because of that $12 million operating loss, we have only promised our employees that the 401k match that we would normally make to their retirement plans, we're only going to be able to do half of what we would do in a full year. So if these FEMA funds come forward, then there's that opportunity for the board, who has the discretion under the way that the plan has been written. They have the discretion to say, wow, because of this this windfall, that we're going to do a full match in the 24 plan year. So.
Okay, thank you. You mentioned cash on hand, so I'm just going to test you a little bit.
Yeah.
Where are we at right now? This group has been with us. They've they've seen it when we went below where we were supposed to be, and I know we've been
Right.
creeping up. Where are we at?
Yeah,
Do you know?
so Melinda Tupper, our Chief Financial Officer, in fact, she'll be reporting this afternoon, late this afternoon, early evening. She'll be making her financial report to the board, and she will share with them not only how we did in the month of June, but how did we finish the fiscal year, which ended on June 30, 2024. She will share with the board that we have just over 100 days of cash on hand. And again, what does that mean? So if you were to take that essentially $900 million budget and divide it by 365 days, that would tell you how much does Kuya spend every day on its operations. It's approaching $2.5 million a day. And then you say, okay, how much cash do you have on hand? And it's not cash, they're invested. They're all invested. But how many times could your cash reserves cover that $2.5 million of expenses? That product of that division, dividing cash on hand by the $2.5 million, that is what days cash on hand mean. It's a measure of a hospital's liquidity. It's a measure of its financial strength. Our bond covenants, the hundreds of millions of dollars that we have outstanding in tax-exempt revenue bonds that we've issued over the years to fund growth here, we have a promise, a contractual covenant with the holders, the investors that hold the Kuya bonds. And we pledge to them that we will never let that number of days cash on hand fall below 90, because they want to make certain that we're a solid, solvent organization, so that the likelihood that we're going to repay the principal and interest on the bonds, that investment they hold, they want to make certain it's really high. And so if we ever go below 90 days cash on hand, then we are in default of that covenant. We have broken our promise or pledge. But the bondholders can give us a waiver. They can forgive us for that, and they have for this period that we fell below. Our lowest level ever was 62 days back on March 31st, 2023. And so we certainly have rebounded significantly since then. We are now above that 90-day threshold, not a whole lot above it. I think the highest I can remember pre-COVID, we were about 170 days cash on hand. There's a second financial covenant called debt service coverage ratio. And that's basically taking your total net income, that bottom line, you get to add back depreciation expense, and that gives you what's called income available for debt service. You then divide that by the largest amount of principal and interest you ever have coming due in any future year on your debt. And so it's basically telling you, how much income do you have to cover that principal and interest that you owe to those bondholders. So we were in default of that measure too, pretty much over the entire 4 years of the pandemic. At June 30, 24, for that fiscal year end, we're back in compliance. So we're now in compliance with the two financial covenants. But you have to be in consecutive compliance for 2 years in a row before you're considered out of default, and we can bring back that $18 million that we had to move.
That was my question. How long? Oh, shoot.
2 years. So June 30, 24, and then June 30, 25, which again, if FEMA comes through, highly likely that will...
Is that the same time limit that we need to be out of default before our credit rating goes back to an A?
They're really, they're unattached to completely. So Moody's, who rates our credit worthiness, definitely affects the interest rate that we would pay. If we were to go out and do a new bond issue, your credit rating has a huge impact on what interest rate you're likely to pay. Obviously, the worse your credit rating, the higher the interest rate, because those investors are taking much more risk. So we are a Baa1 from Moody's. Our credit outlook got upgraded from negative to stable just about a year ago, so that was very positive. But Moody's would probably want to, they're going to be very happy with us when we tell our story. We have a rating session with them every year. They're going to love to see the story of recovery. They're going to be disappointed to hear about fiscal 25 and that $12 million operating loss, but they're gaining confidence in our ability to continue down this path of recovery. So they may not be ready to upgrade yet. They could go up because we went from an A3 to a BA1. That's 4 clicks down. So they might take us up, a click or two, but I think it's going to take some proven, results until we get back to that A3.
Well, that's good though. That makes me feel good. I'll take you back to 2016 when we first started the community engagement, and we were talking about going back to the community for another bond, and you were going around the county educating everybody on Cahuilla Health. It cost us $1.7 million to operate the hospital every day. Yeah. So 1.7, now we're at 2.5.
Yeah.
So a lot of growth there.
Yes.
A lot of cost increase.
A lot of that driven by rates, not necessarily volumes or growth. I mean, it's just the inflation in pharmaceuticals and supplies, but probably even more so wages. California ranks number 1 in the nation in terms of the average hourly wage rate for nurses. $61 an hour is the average wage for an RN. There's not a single state that's even close to that. And we're the only state that mandates a minimum number of nurses to take care of patients. So if you're on a medical surgical unit here at Cahuilla, by California law, the most number of patients you could be caring for is 5. If you were in Texas, you might be caring for 10 to 15. So Texas hospitals need far fewer nurses than California hospitals. They also pay significantly less than California hospitals. And so, our cost of labor is exponentially higher here than most the rest of the country. So that's probably what's really driven that 1.8 daily to 2.5.
2.5.
Yeah.
Okay, so we've got a couple of questions and we've got 5 minutes left. So,
Okay.
And I don't want to rush on this, so I want to throw this in. But the question was, did you extend your contract? We know you had 1 more year left, but they had given you the option if you wanted to do an additional year. Did you do that June 30th?
Gosh, I should keep you in suspense, huh? You know the answer.
I know the answer, but I want to...
Yeah, so thank you. Yes, so my current employment contract with Cahuilla is scheduled to end on June 30, 2025. But I had the option to extend that retirement date by 1 year to June 30, 26. But I had to inform the board 1 year in advance. So they had to know by June 30, 24 if I planned to exercise that option or not. And so I kind of waited to the last minute. I guess I could have called them on Sunday, June 30th, but I let the board know on Friday, June 26th, that I wanted to exercise that option, and they have supported that. And so my new formal retirement date will be June 30, 2026.
All right.
Yeah.
Well, you bleed blue and orange. That's
know.
all I can say, Gary.
No.
Well, that's very good for us. So thank you for that.
Very good for me too.
Yeah, thank you for that. And hopefully Kathy is okay with that. I know you've got a couple of grandkids that you guys are going and seeing a lot on the weekends.
Yeah, and I appreciate the board. They're very incredibly supportive of me, and I'm extremely grateful. But they'd like to see me take a little bit more time off, so we'll take more road trips.
Well, how about set the goal of 2026 when you leave, you have no PTO to pay out? How about that?
Okay.
Okay, so I've got a couple more things to ask. The Da Vinci robot.
Yes.
Okay, so we have the question that some of the residents were telling a community member that there are a lot of people who have the ability to use the robot, but there's only one robot. So does Cahuilla have any plans to get a second robot, or a second or third? And then he said there are a lot of secondhand robots that are very functional. But then so I reached out to our director of surgery and just asked her how many surgeons are trained to work on the Da Vinci, and she said quite a few. So she
Okay.
didn't give me a number. She said quite a few, all urologists, all general surgeons, and gynecologists.
Yes.
So
So I remember when we bought our very first Da Vinci robot, and I want to give a shout out to the Cahuilla Health
foundation,
Hospital Foundation. Probably a number of you that are on this video today are members of that foundation or contributed to the campaign to raise money to buy our first robot. I think we originally bought it at the urging of Dr. Marty Pra, who's a urologist who I don't believe uses the robot anymore. So even though he's trained on it, he doesn't. I know Dr. Ford, Joe Ford, uses it pretty extensively. I don't know about Dr. Rosenberg, another urologist. I do know a number of OBGYNs that use it as well. So it is popular. We actually have purchased, we purchased a newer, I don't know if it's the Da Vinci SI2 or Christine would know the model number, but several years ago we purchased the next evolution of the robot. That was really at the urging of Dr. Ford, and its functionality and capability much better. But we did trade in that old robot. It's hard to buy lower evolution, like say a lot of used, refurbished, but generally the older models. It's pretty hard to be the surgeon that has to use that one when you have all the bells and whistles on the new one. So they're very expensive, between $2.5 and $3 million. So, when you only have a $14 million capital budget, you have to be pretty selective. So we just are able to afford the single robot right now. Again, that could change if FEMA were to come through. That would be the kind of thing that you'd use FEMA for, where it's a one-time purchase as well that's going to last you for many years. So I wouldn't rule out a second robot. I hear lots of requests for that second robot, and to hear more and more surgeons are using it. The robot definitely has its value. Faster recovery from surgery, more intricate surgery that can be done using the robot, being able to move its hands, we'll say artificial hands, into places that the human hand has difficulty. But it's also very, very expensive. The arms that are used on the robot are all disposable, and they are designed in a way that builds in obsolescence, so that the company Intuitive that makes the robot literally restricts the number of times that you can use that arm before you have to buy a brand new one, even though it's perfectly fine, but 10 clicks and you buy a new one. So the disposables are very, very expensive on the robot. So you need to balance, doing it more the traditional way. I've talked to many obstetricians who believe, some will swear by the robot for hysterectomies. Other OBGYNs will say, I can do it faster and better without the robot. Same with removing gallbladders, doing cholecystectomies, which instead of, you don't open patients anymore, it's all done laparoscopically. And you could do it on the robot, but maybe you could do it just as effectively off the robot, and it's less expensive. So, and you don't generally get, unfortunately, the payers have not kept up with the advances in technology. So you don't see, you're using the robot, very expensive technology, very expensive disposables, so we'll pay you a much higher rate for that. You don't see that happening. So
Good information. Okay, somebody else wants to spend more of that capital budget.
Uh-oh.
How much of that money is going to helping us replace the elevators?
Whatever it takes. Whatever it takes. So unbelievable. Yeah, this is having them all go down at the same time is incredibly frustrating. We're taking the generator out of one to, update the second, and then it goes down. And so we've had so many, it's hard to get parts. There are only a couple elevator manufacturing companies in the I don't know, world or country. There's only a few companies that have the certifications and the qualifications to service them, and so we're at their mercy. And so we have a number of generators and other critical sensors and other parts of the elevators that have been out waiting to be, refurbished for months and months. Getting the service companies to come out. So we are replacing, I think it's, Kevin Morrison told me, it's about $1 million a piece for an elevator. And so we are currently working on replacing some of the elevators, as well as continuing to refurbish and renovate the newer elevators, newer being relative, So yeah, our plan is to have them all up and running, and we will take whatever it takes to make that happen.
Right. And we hear this from community members, of course, our patients and our employees.
Yeah, no,
all
I
of
know.
our employees are running around this place
Yes.
too. So
Even an elevator in our Sequoia wing. Now, it opened 15 years ago, but we have elevators in the Minnow King wing from 1969, and we just had an elevator go down in the Sequoia wing, which was very frustrating. To an elevator of that age to be experiencing problems. So I don't know.
well, Gary, you've answered a lot of questions. We're slightly over, so we just want to thank you guys.
Thank you again for joining us in today's telecast. It's nice and cool in here. Thank you. It was 100 and whatever when I was walking over. But even a hot breeze, I guess, is better than no breeze. Huh? Just want to thank you all again for being a part of our community engagement initiative, continuing to stay with us. Thank you for your great questions, those you gave in advance and those that you chatted in. And as Deborah and I always say, you don't have to wait till next month's broadcast. Anything on your mind, anything you're hearing out there, shoot me an email, shoot Deborah an email. We're very happy to answer those in our transparent, forthcoming manner that we do here. So,
All right, thank you.
Wish you all a great weekend.